professor. When we are talking about her publications, she has published approximately 6 publications on various topics. So I would like to request ma'am for the presentation. Okay, so over to you, ma'am. Should I name it? Should I name it this one? Yes, I'll do that. Yeah. And then questions answer sessions we will do at the end like before. Okay. First we will do the presentations, and once the presentations will over, then only we will do the discussion. So I request all the participants to please mute yourself, and if you want to ask any queries, write down in a chat box. We will take up your questions at the end of the session. Okay.
Good afternoon, everyone. So today is the third series of the presentation, and we'll be starting with invasive mechanical ventilation. So if you see the learning objectives for today's class, so we're going to understand the basics. So we are going to start with the basics of respiration. Then we are going to explore what are the indications and what are the goals of mechanical ventilation. Then we'll familiarize ourselves with the normal parameters of mechanical ventilation. Then we'll do a very brief overview of the various modes of mechanical ventilation. We'll be discussing one historical and the 3 most commonly used basic modes of ventilation. After that, just like with any procedure, we'll be going on with the complications associated with mechanical ventilation. Then we're going to go with the last topic, that is weaning. How do we start with discontinuation of mechanical ventilation? So if we go on to the basics of ventilation, we have to first see the respiratory anatomy. So the respiratory anatomy will include the airway. The airway starts from the nose, goes into your nasal cavity, nasopharynx, oropharynx, laryngopharynx, and then your larynx. Then comes your trachea, which divides into bronchi, right and left. After that, it goes into many small subsegments to ultimately reach these small areas. The small areas where actual gas exchange takes place is known as the bronchopulmonary unit, which consists of the alveolar duct and hundreds and thousands of small sacs called alveolar sacs. If we see a magnified image of the above segment, we will see that every alveolar duct has its own bronchial artery, and then it has its pulmonary vein. Now what happens is that fresh air which comes into the alveoli carries oxygen. Now deoxygenated blood from the body comes via pulmonary vein and it lines the alveoli. Here gas exchange takes place, carbon dioxide goes into the alveoli and oxygen comes from the alveoli into the pulmonary veins and capillaries. These capillaries join to form the pulmonary artery. These pulmonary arteries then join to form large right and left pulmonary artery, and they eventually drain into your left atrium. From left atrium, the oxygenated blood is carried to the left ventricle and thereby via aorta to the rest of the body. Now, if we see the mechanism of breathing. So, breathing is an involuntary process. The brainstem controls the breathing. Chemoreceptors give continuous supply sensory input to the brainstem, from where the stimulus for respiration goes to your phrenic nerve. Phrenic nerve causes the diaphragm to contract, and this leads to a chest wall expansion. The chest wall expansion will lead to an increase in intrathoracic volume. Consequently, it leads to a negative intrathoracic pressure. Now, if the intrathoracic pressure is negative, air flows from the atmosphere to the alveoli, from a high to low pressure zone. This is known as negative pressure ventilation, which is the normal breathing which occurs in human beings. Following is a graphical diagrammatic representation of what I have said previously. The stimulus from the phrenic nerve leads to downward movement of the diaphragm. This downward movement of diaphragm leads to increased volume of the interthoracic cavity. Increased volume translates to a lower pressure, which causes passive movement of air from the atmosphere via the airway to the alveoli. Now, what is mechanical ventilation? If you see the definition of mechanical ventilation, it can be defined as a technique through which gas is moved towards the lungs through an external device connected directly to the patient. So in the diagram, you can see what we see in ICUs. This machine over here is the ventilator. From the ventilator, there is a tubing which is going to the humidifier. This is known as the inspiratory limb. This air, after humidification, warming, goes to the patient via the inspiratory limb. This is the Y connector, which is then connected to an ET tube. This movement will lead to inspiration. Once the positive pressure from the ventilator is stopped, passive expiration takes place through the expiratory limb, and then the air goes back to the ventilator. So the use of a ventilator is to move the room oxygen into and out of the lung mechanically to maintain proper oxygen levels and carbon dioxide in the blood. Now, what are the goals and purposes of mechanical ventilation? Now, mechanical ventilation per se does not treat the underlying pathology, but it buys the patient time so that the underlying pathology can be corrected. It helps in improving the gas exchange. It helps in relieving of respiratory distress. Respiratory mechanics or the pulmonary mechanics are improved by the support from the ventilator. It permits lung and airway healing. It reverses hypoxemia. It relieves the acute respiratory acidosis. If the patient has increased partial pressure of carbon dioxide, that leads to respiratory acidosis. Supplementation of ventilation, increasing the mechanical ventilation, leads to loss of the carbon dioxide and thereby corrects the respiratory acidosis. In case the patient has respiratory muscle fatigue, then the ventilator helps to reverse that as well. It also helps in prevention and reversal of atelectasis. Atelectasis is defined as the closure of the alveoli. It also helps in improving the lung compliance. Lung compliance is the change in lung volume per unit pressure gradient that is applied. Now, if we see the indications of mechanical ventilation, we can broadly categorize them into the following headings. Acute respiratory failure. Second is prophylactic ventilatory support, where we expect that the patient will not improve and the condition is going to worsen in the future. So we prophylactically put them on ventilatory support. Then hyperventilation therapy is also used as an indication, such in cases of head injury. Here we put the patient on mechanical ventilation to normalize their carbon dioxide and oxygen pressures. Now, the various examples of prophylactic ventilatory supports are clinical conditions in which there is a high risk of future respiratory failure. Examples are brain injury, a road traffic accident where the patient has the traumatic brain injury, or patients who are having intracranial bleed, in which we expect that the recovery is going to take time. Here, prophylactic ventilatory support is given. In cases where there is heart muscle injury, such as MI, there also a patient may need mechanical ventilation. Major surgeries where the duration of surgery is prolonged more than 12 hours, patient is hypothermic, massive transfusion has gone. So here also we electively or prophylactically ventilate them overnight for 24 hours. Prolonged shock where the patient is on multiple inotropes and there's associated lung injury. Here also prophylactic ventilatory support is given. Smoke injury or inhalational injury to the airway is one place where we prophylactically intubate patients, especially if there is singeing of the nostrils, there is soot in the nostril, there is soot inside the patient's airway in the pharynx, and the patient coughs out black sputum. Here we prophylactically intubate them before worsening of inhalation injury actually occurs. Now, what is the purpose of ventilatory support? It decreases the work of breathing so that the muscles do less work and the patient gets time to rest. It minimizes the oxygen consumption and it decreases the hypoxemia. It also reduces the cardiopulmonary stress. This is the stress that occurs on the heart due to a stressed respiratory system. There are conditions where we have to give deep sedation to the patients. And in such conditions, we can lose the airway if the patient is not intubated. Contraindication to mechanical ventilation or a positive pressure ventilation is untreated pneumothorax. Now, what happens if we start mechanical ventilation in a patient who has closed pneumothorax? Positive pressure ventilation causes a closed pneumothorax to convert slowly to a tension pneumothorax. And if the patient develops tension pneumothorax, the patient will become hemodynamically unstable and will have life-threatening hypoxia. So we first need to address the pneumothorax. We need to put an ICD and make sure that the ICD is working properly, and only then do we start with mechanical ventilation. The other contraindications are relative, such as patient's informed consent. If the patient doesn't consent to mechanical ventilation or intubation, we cannot start mechanical ventilation. Medical futility. This is a controversial topic. So if the patient has a condition where there is a reasonable doubt that the treatment is not going to treat or improve the patient condition, here putting them on mechanical ventilation is not going to help the patient. So it is considered as a relative contraindication. Reduction or termination of patient suffering in pain is a relative contraindication. So this is a picture which shows that a patient is having a large black area. This large black area is a pneumothorax. If we see carefully, the entire right part of the hemithorax is filled with air, and this small collapsed area is the right lung tissue. There is deviation of the trachea from the midline to the left side. Simultaneously, even the mediastinum is shifted entirely to the left side. So this is most likely a tension pneumothorax. And here, an ICD will have to be inserted, or a prior needle decompression in the second intercostal space will have to be done to stabilize the patient, and thereby buy us time to put an ICD. Now let us study about respiratory mechanics. Now ventilation can occur only if there is a sufficient pressure which is applied. This sufficient pressure is needed to overcome two kinds of forces. One is the elastic force, that is defined as compliance, the amount by which the lung distends per unit of pressure applied. The second is the viscous force. The viscous force or the resistance. This is the resistance to air within the tube and the various part of the tracheobronchial tree that occurs. So the tube part refers to the ET tube, the trachea, the bronchi, and the bronchioles, which offer resistance to the flow of gases, the resistive force. The elastic forces are the force which is the elastic recoil of the lung tissue and the force that the chest wall applies on the pleural cavity. These forces resist any distension or collapse of the lung. Now, the other terminology that we need to know about is the airway pressures. So we'll be discussing three different pressures. The first one is the peak inspiratory pressure, also referred to as PIP. This is the pressure used to deliver the tidal volume by overcoming the non-elastic, that is the airway and the resistance offered by the airway and the trachea and the bronchioles. And the other is the elastic forces, which is the lung parenchyma. The second pressure is the pressure needed to maintain the lung inflation in the absence of airflow. This is also known as the plateau pressure. Now we need to know the two types of invasive positive pressure ventilations. There is one in which there is full support to the ventilation. Here, the ventilator provides all the energy required to maintain effective alveolar ventilation. Here, the patient has no control over the ventilator support. The second one is the partial ventilatory support, where the ventilator parts provides only partial support, and simultaneously the patient participates in the work of breathing. And this helps to maintain effective alveolar ventilation. Now, there are three different types of breath delivery. First is a controlled breath delivery. Over here, the ventilator has entire control of the breathing. So the ventilator will control the timing, or it will control the tidal volume. Or there can be a mode where both the tidal volume and the timing, that is the rate of the ventilator, is completely controlled by the ventilator. The second, on the opposite spectrum, is the spontaneous mode, where the patient controls the timing, that is the rate of the breathing, and patient can also control the tidal volume. The extent to which the patient generates negative intrathoracic pressure by taking a spontaneous breath will determine the amount of tidal volume delivered by the ventilator. The third mode, which is in between the two, is known as assisted mode. Now, it has the characteristic of both the controlled as well as spontaneous breath. So, the patient over here can trigger a breath and lead to cycling of breath. But each of these breaths are supported by the ventilator. So, if the patient is not triggering, the ventilator will give only mandatory breaths. But if the patient is trying to generate a breath, that is, the patient is triggering a breath, over here, the ventilator is going to support the breath. Now we'll discuss the various control variables. So there are two ways of having controlled ventilation. One is the first mode where you have a volume control. So this is also referred to as volume preset. Over here, the fixed parameter is the tidal volume. So we can only fix the tidal volume. Now, depending upon the patient characteristics, the characteristics of the tubing and the sedation, the airway pressure will be variable. The constant factor will be the tidal volume delivered. So if the lung characteristics are changing, the pressure which is needed, or the pressure that the ventilator needs to generate that prefixed tidal volume, will vary. So over here, a fixed flow rate is there. So if there is asynchrony between the patient and the ventilator, insufficient flow may lead to hypoventilation, or it can lead to ventilator asynchrony or dysynchrony. In volume preset, it becomes very, very important to monitor pressure, because if the pressures are not monitored correctly, if there is a kink in the circuit, or there are secretions, or the patient is not adequately sedated, here patients can land up having very, very high pressures. So the other ways in which ventilation can be controlled is volume controlled. This is also known as pressure preset. Over here, the set parameter or the fixed parameter is the airway pressure. Now, depending upon the dynamics of the lung, the circuit configuration, or the status of the patient's sedation, the tidal volume delivered will be variable. So over here, the tidal volume varies with the change in lung characteristics. The flow will vary according to the patient's demand. So if we see the pressure and time scalar, how the pressure varies with time, following are the various types of pressures that you see in a ventilator graphic. With the beginning of inspiration, the inspiratory pressure starts to increase. As the inspiratory pressure starts to increase, a maximum peak pressure is obtained. Over here, this pressure is known as the peak inspiratory pressure. Now, once the flow of gases has stopped, the amount of pressure that is needed to distend the system is known as the Platt pressure. Once the Platt pressure or the plateau pressure starts to decrease, over here the exhalation valve opens, and this is the beginning of expiration. After the expiration is over, there is still some pressure that is given by the ventilator. This is known as the third pressure, that is the positive end expiratory pressure, also known as PEEP. So whenever a patient triggers a breath, that is, there is a fall in pressure or there is a decrease in flow, Over here, the breathing starts. This is known as trigger. This is the highest pressure that we have set. This is also known as the limit. This is cycling. When one phase of respiration changes to other, the switching from inspiration to expiration is known as cycling. So what determines whether the respiration will start or not is known as trigger. So that can either be machine initiated, that is time will determine when the breathing starts and when the breathing is over, or it can be patient initiated. Any increase in flow or any decrease in flow can lead to trigger or the starting of a breathing. The other target is known as limit. This is the maximum value that when attained by the ventilator, the breathing stops. The inspiration or the flow stops. It can be volume, it can be pressure, or it can be flow. Cycling is what determines the switching from one phase of respiration to another. So it can be time, it can be volume, it can be flow or pressure. So before we start discussing the modes of ventilation, we'll have to familiarize ourselves with the common terminologies that we'll be using. The first is tidal volume. It is the amount of air that is delivered to the patient per breath. It is expressed in terms of millimeters. The common starting point for ventilation is 8 to 10 ml/kg per kg of idle weight. This is, however, not fixed. There can be conditions where we start with 6 ml per kg also. Conditions such as ARDS, there we start with 6 ml per kg and we can go to as low as 4 ml per kg. The second is frequency, which is also the respiratory rate. This is nothing but the number of breaths that the patient is given per minute. So it can be fully delivered by the ventilator, or it can and it can be contributed by the patient as well. So the commonly set respiratory rate is near the physiological rates, which is 14 to 12 per minute. This can be higher in pediatric patients and can be lower in patients with COPD who, as a part of their pathophysiology, take large volume and low respiratory rates. Cases such as ARDS, there also we take higher respiratory rates above 20 per minute. So this is just a general recommendation. It's not absolute.
Yes.
The next term that we have to see is minute ventilation. It is the product of tidal volume multiplied by frequency. It is usually expressed as liters per minute. So another thing that we will be talking about now subsequently is the exhaled tidal volume. It is the amount of gas that actually comes out of the patient's lungs on exhalation. This is the most accurate measure of the actual volume that is received by the patient or that is actually delivered by the ventilator. If the exhaled tidal volume deviates from the set tidal volume by 50 or more, then we need to troubleshoot it. And we need to find out the source of gas loss or gas leak. The most common sources are either a damaged ventilator circuit or the viral filters or the connections to the tubings. The last parameter that we'll be, second last parameter is inspiratory to expiratory ratio, also known as IE ratio. So it is the ratio of the duration of inspiration and the duration of expiration. During spontaneous breathing, it is near 1/2, and that is what we usually give to patients. However, if patient has pathology where patient needs a longer duration for exhalation, here something known as breath stacking can take place. It is also known as autopee. So if the exhalation time is too short, patient is not able to exhale the previous breath. So before complete exhalation, a subsequent breath from the next cycle is given. So this leads to breath stacking or autopee. This is classically seen in COPD, where the pathology is in the obstruction to expiration. These patients need a larger expiratory time. So for them, we will be choosing an IE ratio of 1:3 or 1:2.5. 1:2 will be insufficient for them and it may lead to autopee or barotrauma in the long run. The last pressure is PEEP that I have explained previously. It is the amount of pressure that is maintained at the end of expiration. The typical settings is to start at 5 and thereby increase if needed. Maximally, we give up to 20. So what is the function of PEEP? PEEP, firstly, it helps to keep the airways open. So it prevents atelectasis, it prevents collapse of small airways. Additionally, it increases the functional residual capacity. So here we can see that in cases of ARDS, we can use a PEEP of up to 20 centimeters of water to improve oxygenation. Peak airway pressure, as I've already told previously, is the maximum pressure that is required to deliver the tidal volume. Plateau pressure is the pressure that is needed to distend the lung. It is the pressure that is there within the lungs when no gas flow is taking place. So peak inspiratory pressure can range between 10 to 40, and the target is always less to 40. So following are the parameters that we need to know, as discussed previously: tidal volume, PEEP, the mode, and the rate, and the amount of oxygen that is given. IE ratio is also one of the parts of ventilator settings. Now we'll come to the next topic, which is the mode of mechanical ventilation. So on one end of the spectrum, we have a continuous mandatory ventilation, which can be either pressure control or volume control. This is a fully controlled mode of ventilation where patient cannot initiate a breath, the patient cannot contribute to ventilation at all, as in the ventilator doesn't take it into any account. The second mode of historical importance is assist control ventilation, where patient can trigger the breath. However, the support that the ventilator gives is always constant. Third is a mode which is in between, synchronized intermittent mandatory ventilation, in which the mandatory component of the ventilation can either have a pressure control or volume control. That is, a fixed peak inspiratory pressure or fixed tidal volume is given to the patient in the mandatory breaths. The third, the last mode of ventilation on the opposite end which is pressure support ventilation, in which patient is in full control of the respiratory rate. What we can change is the FiO2 and the pressure support that the ventilator is giving. So the first mode is controlled mechanical ventilation. In this mode, the ventilator provides a mechanical breath on a preset timing, that is at a fixed respiratory rate. Patient respiratory efforts are completely ignored. So the disadvantage of this mode is that it can be uncomfortable for children and for those adults who are conscious. These can only be used in patients who are unconscious. That is, these patients will need a moderate to deep amount of sedation so that there is no asynchrony between the patient and the ventilator. So over here, we can see that this is a pressure scaler. That is the graphical representation of pressure with time. This leads to the beginning of the opening of inspiratory valve, increase in pressure, attainment of peak pressure, followed by fall in pressure. Over here, we can see that there are no spontaneous efforts generated by the patients. Spontaneous efforts generated by the patient are reflected as small dips, also known as triggers. The next mode is assist control mechanical ventilation. So this is an old mode which is not conventionally used, even though ventilators do have them. So what we have fixed over here is the tidal volume and respiratory rate. So thereby a minimum minute ventilation is guaranteed. Additionally, patient can trigger additional breaths. Now, whenever a patient triggers a breath, these additional breaths that are given by the ventilator are fully supported. So if the patient breathes above the set rate, the machine is going to give the same tidal volume, irrespective of the fact that whether the patient needs it or not. So the disadvantage of this mode of ventilation is that the patient can lead to hyperventilation, and this hyperventilation can lead to respiratory alkalosis. So following is the graphical representation of the various scalars of assist control ventilation. So this is the flow scalar, which is, we can see that there is constant flow. Okay. In second flow, you can see that this negative deflection is triggered. So the patient is trying to generate a spontaneous breath. That is, the intrathoracic pressure is falling with every time patient tries to breathe. This negative or the fall in pressure is triggering the ventilator to give a breath. Now, whenever there is a trigger, the ventilator is going to give the preset tidal volume. This is also a triggered breath where patient is getting full tidal volume. The third breath we can see is the third breath at the set respiratory rate where there is no trigger. This also the ventilator is going to give a fixed tidal volume as set by the ventilator. As you can see in all the three breaths, the same amount of tidal volume is given. The third mode is synchronized intermittent mandatory ventilation. This is a mode which is most commonly used in ICU, though not recommended. Over here, we have a preset mechanical breath. This preset mechanical breath can either be pressure controlled or volume controlled, thereby making pressure as a limiting factor or volume as a limiting factor. And the respiratory rate or the mandatory ventilatory rate is set. Now, suppose we have set a mandatory breath of 12. So the respiratory rate is going to be 12. That is, these are going to be 12 set mandatory breaths. Every 5 seconds, the patient is going to give a mandatory breath, irrespective of the patient's spontaneous efforts. Now, within the cycle time, if the patient tries to initiate a breath, so this initiating breath will be sensed by the ventilator. And once the ventilator senses that the patient is breathing, it will deliver the preset ventilator breath. However, if the patient fails to initiate a breath, the ventilator will deliver a mandatory breath at the end of breathing cycle. Additional spontaneous breaths are allowed in between the breaths, but these will not trigger a full mandatory breaths. Only additional support will be given by the ventilator, which has been set in the ventilator. This is the most commonly used weaning mode in the ICU. The last mode, which is on the opposite end of the spectrum, where patient has a lot of control over the ventilation, is pressure support ventilation. Here we can see that it is a spontaneous mode. Here the patient initiates the breath, the ventilator sends the breath, and it delivers a preset inspiratory pressure, that is the pressure support that is set by the ventilator to help overcome the airway resistance and to support the breath. Here the patient controls the rate and the tidal volume, thereby controlling the minute ventilation. So depending upon the patient's need, the tidal volume is variable. The tidal volume will depend not only upon the pressure support that is set in the ventilator, it will also depend upon the patient's own efforts. It can be simultaneously used with SIMV, or it can be used alone in the CPAP mode as well. It is very, very important to set the correct backup alarms when we are using pressure support ventilation. So we need to send a low tidal volume alarm. Suppose the patient is not initiating a sufficient amount of negative intrathoracic pressure. Over here, the pressure supports given by the ventilator may not be adequate. So a low tidal volume will be delivered, thereby leading to a low minute ventilation. So these alarms have to be set with due consideration. Also, an apnea backup has to be put. Suppose the patient stops breathing. So within the set time, the ventilator will go to a backup mode where a backup respiratory rate and tidal volume will be delivered so that the patient is not at risk for hypoxia. Lastly, we'll come to complications of mechanical ventilation. So the first is asynchrony. If the patient and the ventilator are not in line with each other, the ventilator can develop asynchrony, and the patient may be bucking with the ventilator. Autopeep, as I have previously described, when the expiration is not fully complete and a subsequent breath is delivered, it can lead to development of autopeep. It can also lead to alveolar damage and cause pneumothorax. The third is barotrauma. So in cases where volume control modes are used and the correct pressure alarms or the pressure limits are not set, inadvertent high pressures can be delivered to the patient, leading to barotrauma. Other complications of mechanical ventilation are hemodynamic compromise due to the positive airway pressures and the intrathoracic pressures. These lead to fall in venous return and thereby decrease in cardiac output. and lead to a hemodynamic compromise. Other complications can be nosocomial infection, aspiration before intubation, aspiration during mechanical ventilation. So the ET tube cuffs have to be checked every shift 6 hourly in the ICU so that aspiration doesn't occur from the microchannels that are formed around the cuff. Ulcers, gastritis, malnutrition can occur in ICU. Other very, very important thing that we need to consider in patients who are going to be on mechanical ventilation for more than 1 week is muscle deconditioning or the atrophy of the muscles. Once the phrenic nerves stops firing, the diaphragm will get atrophied and it will lead to thinning and decreased shortening of the diaphragm on breathing. This can also lead to vent dependence or difficulty in weaning later on. So a little bit about ventilator alarms. So ventilator alarms are the alarm sounds to alert the staff of the ICU. It is caused due to any abnormal value. It can be either a patient factor or a ventilator factor contributing to the ventilator alarm. These alarms can be divided into 3 types: pressure alarms, volume alarms, and the third one, which is apnea alarms. So here we are going to see the most common causes of alarms. So high pressure limit, low pressure, high respiratory rate, and low exhaled volumes. So the most common pressure that we usually see in ICU is a high pressure limit alarm. So numerous factors can lead to high pressure limits. So secretions or any blockage in the airway can lead to high pressure alarms. So if the patient is not getting adequate suctioning, if the patient is not getting adequate physiotherapy, or the patient is too deeply sedated where the patient cannot cough out. So these secretions build up either in the bronchia, bronchioles, or ET tube and lead to high pressures. Any kink in the tubing, any kink in the tube can lead to high pressure limit alarms. Patient biting can lead to decrease in the cross section of the ET tube and thereby increase the pressure. Patient coughing, gagging, or patient trying to talk can also lead to these alarms. Other emergencies which can lead to increased pressure is a bronchospasm. So the bronchioles can constrict and decrease in the diameter. These lead to high pressure alarms. So on auscultation, we can hear wheeze, and in severe bronchospasm, we can hear a completely silent chest. Another dreaded complication of mechanical ventilation, which also leads to high pressure alarms, is pneumothorax. This is an emergency. If not dealt in time, can lead to tension pneumothorax and patient collapse and cardiorespiratory arrest as well. The other subset of alarms are the low pressure alarms, which can be because of 2 malplacements. Either the tube is out, it is in the cuff is no longer inside the glottis. Then we can have low pressure alarms, or any disconnection in the ventilator tubings can also lead to low pressure alarms. The third one, which is quite oftenly seen in ICU, is high respiratory rate. And this is also can be due to multiple reasons. Patient anxiety, patient pain, secretions in the airway, hypoxia, hypercarbia, all can lead to hyperventilation. Fever can also lead to high respiratory rate. The last one is low exhaled volume. Any disconnection or leak can lead to low exhalation volume alarms. So occurrence of another alarm can, suppose the patient has bronchospasm where sufficient tidal volume is not being delivered. So we can see a combination of high pressure limit and low exhaled volume. So there are 2 golden rules of alarms in ICU. One, alarm should never be silenced until the cause has been addressed. And while the cause is being addressed and we cannot find the source, the patient is to be disconnected from the ventilator and connected to an ambu bag, that is a handheld resuscitation bag for manual ventilation with 100% oxygen till the problem has been resolved. So we'll come to the last part of the slides, that is weaning. So what is weaning? It is the process of withdrawing mechanical ventilatory support and transferring the work of breathing from the ventilator to the patient. Now, there are 2 subsets of patients. There are some patients who will tolerate the abrupt removal of ventilatory supports. This is usually those patients who have received ventilator for a very short period of time, where the cause is known and is usually corrected in 1 to 2 days. For other patients who have an underlying pathology that we do not know about, or is a pathology which is going to take long to heal, over here we need to proceed with gradual weaning, that is gradual withdrawal of mechanical ventilatory support in a phased manner. So there are 3 types of outcomes when you do weaning. One is weaning success, when after removal or extubation, we do not need any ventilatory support for the subsequent 48 hours. This is known as weaning success. Weaning failure is when failure of spontaneous breathing trial or need for reintubation within 48 hours of extubation. Bridging in between the two is weaning in process, where patients who are extubated, but they need ventilatory support by non-invasive means. So this can be NIV or it can be HFNC, as has been previously discussed yesterday. So we need to see multiple patient conditions before we take the decision to wean or not. All these factors have to be addressed and corrected before we even think about weaning. Because if all these conditions are not met, we will lead to weaning failure. So they are categorized broadly into 3 factors. One is the patient, second is cardiac circulatory, and third is the dietary acid-base electrolytes. So if the patient is still having fever, infection, renal failure, sepsis, and if the patient is not adequately rested, we may land up with weaning failure. Other cardiac factors that we need to take into consideration is absence of arrhythmias, a normal blood pressure, normal cardiac output, patient who is having a normal fluid balance, patient should not be dehydrated or have fluid overload. Patient having severe anemia, HB less than 7, have high chance of weaning failure. Patients who are in calorie deficit or those who have acid-base imbalance and electrolyte imbalance often lead to weaning failure. So following are the common weaning criteria that we need to see. These are broadly categorized into 3 parts: clinical criteria, ventilatory criteria, and oxygenation criteria. Clinical criteria, may we have to see whether the acute phase of the disease or the primary pathology due to which the patient has come to the ICU, that is addressed, or is it in the resolving phase or not. Simultaneously, patient needs to have adequate cough. Patient has to be able to expectorate the secretions. If the patient has copious amount of thick secretions, patient still needs a tube for tracheal toileting. In these conditions, if we try to wean, we'll land up in weaning failure. Patients have to have hemodynamic stability. Patients on multiple inotropes, patients who are dehydrated cannot be weaned. If we try to wean them, it will again lead to weaning failure. Now, we also need to see the ventilatory criteria. So if a patient tolerates a spontaneous breathing trial for more than 30 minutes, this is in favor of continuing weaning. Patients need to have a PCO2 of less than 50 mmHg and a normal pH, that is pH of more than 7.25 to even consider weaning. On spontaneous breathing, patients should be able to generate a tidal volume of more than 5 ml per kg. The minute ventilation should be less than 10 liters, that is, the patient should not have air hunger or respiratory distress, and ABG should be within normal limits or should be acceptable. So oxygenation criteria will address all the ABG findings. So the patient should have an arterial oxygen tension without PEEP of around 60 with an FiO2 of 0.4. Patient with PEEP of less than 8 should have a PaO2 of more than 100. Saturation should be more than 90%, and PF ratio, which is the ratio of arterial oxygen tension and the fraction of inspired oxygen, should be more than 150. Now, there are various ways of doing weaning. First, we'll discuss the spontaneous breath trial. So over here, the patient is abruptly discontinued from full ventilatory support and placed on a spontaneous breathing mode. This can be done via 2 modes. Patient can either be put on a T-tube for 30 minutes, or the patient can be put on low level of pressure support on the ventilator circuit. Over here, we give a pressure support of around 5 to 6, which is the amount of pressure support which is needed to breathe against the resistance of the circuit. Criteria for passing SBT. When do we say that the patient has passed a spontaneous breath trial and we can further proceed to extubation? Patient is having a normal respiratory pattern. So there is no tachypnea, There is no use of accessory muscles. So there is no laser flaring, supraclavicular retractions, intercostal retraction and subcostal retractions are not there. There is adequate gas exchange, a normal SpO2 on monitor and a normal PaO2 in ABG. Plus patient will be hemodynamically stable while on the spontaneous breath trial. Now, how do we say that the spontaneous breath trial has failed? So patients who do fail SBT will fail it in the first 30 minutes of the trial. Following the various signs and symptoms of failure, patient will become anxious or agitated. Patient may develop altered sensorium, as in the GCS may drop, may not be responsive. Patient will start sweating and will become anxious. Patient may actually develop cyanosis and the saturation will fall below 90 to 85%. There may be evidence of increased work of breathing, that is, accessory muscles will be recruited for breathing. So the second way of weaning is the SIMV. Though it is not recommended as the standalone mode for weaning, but this is often chosen as the most commonly used mode in the ICUs. So we proceed with a stepwise approach. Initially, we decrease the respiratory rate, that is the mandatory ventilatory rate by the ventilator. Suppose the patient is taking 12 breaths per minute. We will decrease the respiratory rate by 3. So it will be decreased from 12 to 9. If the patient tolerates this, subsequently will again decrease the rate by 3 and thereby eventually go to a set rate of 2 to 4. The logic of doing this is that in small aliquots, we transfer the load of breathing from the ventilator to the patient, such that the patient is taking more spontaneous breath and less of mandatory breaths from the ventilator. If the patient tolerates step 3, then we consider extubation. And while this is going on, we monitor the SpO2 and the hemodynamics of the patient and the general physical condition of the patient. The third mode, which is which was also frequently used, is the pressure support ventilation. So it can be used with SIMV mode or it can be used as a standalone mode. So in pressure support mode, it is a completely spontaneous mode. Here the patient will be taking all the spontaneous breaths on his own. What we will change is the amount of pressure support. So we will start with a high pressure support of around 15 centimeters and we will sequentially start decreasing the support such that patient takes a spontaneous tidal volume of 10 to 15 ml per kg, maintaining the respiratory rate of 25. So subsequently, the pressure support is decreased by 3 to 6 per aliquot till we reach the lowest level of 5 centimeters. If the patient tolerates pressure support of 5 centimeters, patient can be considered for extubation if the blood gases and the vital signs are satisfactory. So what has been seen in literature is that spontaneous breath trials, whether given as a single or multiple trials, leads to quicker extubation in comparison to when we use pressure support mode or SIMV mode for weaning in those patients who are mechanically ventilated for more than 1 week. So there are numerous weaning protocols that can be done. Here is a brief description of safe weaning of patients. So before you decide to wean a patient, we need to ask the following questions. First, has the underlying cause been treated? Second, does the patient have an inspiratory effort? Is the patient trying to breathe? Third, is the patient hemodynamically stable? If the patient is having myocardial ischemia, hypotension, and patient has need of vasopressors, these are relative contraindications for weaning. Third, we also need to see whether the oxygenation and acid-base balance are normal or not. Patients who have a PF ratio of more than 150, requiring a PEEP of less than 8 and pH of more than 7.25 can be considered for weaning. Patients need light sedation for them to be considered for weaning. If the answer for all the above questions is yes, then we can proceed to 7.2. But however, if one of these parameters are not met, we should not consider weaning the patient on that particular day. The same questions have to be addressed next day so that we can consider weaning. The step 2 of the weaning protocol will lead to the calculation of rapid shallow breathing index, also known as RSBI. RSBI is the ratio of frequency divided by tidal volume. Now, when the mandatory breaths are turned off and we use a pressure support of 8 and PEEP of 5 and put the patient on spontaneous breathing for more than 3 minutes. After this time is over, we calculate the RSBI. If the RSBI of patient is less than 100, then the chances of the patient having a successful weaning increases. If this value is more than 105, then the patient is more likely to have a weaning failure. Then we need to again abandon or postpone weaning until next day. And again, repeat the above 2 steps. So if RSBI is less than 100, then we can go to the third steps. In the third step, if patient tolerates a spontaneous breathing trial for more than 30 minutes, that is, patient is disconnected from the ventilator and kept on TPs for 30 minutes or kept on a pressure support of 5 centimeters. If the patient remains stable and has a normal ABG, then we can proceed with extubation. If the answer to the above question is no, patient becomes unstable or agitated or diaphoretic, then we again need to discontinue and reevaluate for extubation the next day. So what are the various indicators which tell us that there is a weaning failure? So it can either be a blood gas analysis parameter, it can be a vital sign, or it can be a respiratory parameter. So in blood gases, we will have an increase in partial pressure of carbon dioxide, that is the respiratory acidosis, leading to a PCO2 of more than 50. Increase in PCO2 will lead to fall in pH. So if the patient's pH falls to less than 7.3, it is considered as weaning failure. Development of hypoxia, either the pulse ox showing a saturation of less than 90%, or ABG showing an arterial tension of oxygen of less than 60, or a PF ratio, that is the ratio of PaO2 and FiO2 of less than 150. Now, the vital signs which may tell weaning failure are, again, change in blood pressure. Blood pressure can increase or decrease by 20 systolic or 10 diastolic. Increase in heart rate by 20 from the baseline or increase above 110 may tell weaning failure. Or new onset arrhythmia or abnormal ECG during the weaning period, it also tells weaning failure. Respiratory parameters which need measurements are decrease in tidal volume, less than 5 ml per kg or 250 ml, increase in respiratory rate or tachypnea more than 30 is also known as weaning failure. So there is no absolute criteria that can guarantee a successful weaning every time. The criteria for weaning here cannot be expected to be accurate at all times and for all patients. These are to be considered with a pinch of salt and to act as a guide, as a starting point for weaning trials. Every patient will be individual. Every patient will have a different underlying pathology and comorbidity. It will have to be individualized for each and every patient. Thank you.
Okay, let's just ask the discussions. So if you have any queries, you can ask your questions here. And I'm very surprised why you are asking post-testing between the presentations. Presentation is not yet over. Everybody is asking post-test here. I think everybody knows that post-test we will give only after the session. I think please be mindful from tomorrow onwards, okay? Because you are asking post-test in between, and then when the chat is popping up, it's creating so much disturbance for the participants who are actually listening the session. Okay, please write the queries. I'm telling, write the queries, and we are giving a post-test and pre-test before the session, post-test after the sessions. I think this idea everybody knows. And those who are asking pre-test now, there is no point. We are calculating your timing also. How many like how many minutes you are joining the sessions. Those who are joining for 5-10 minutes only for pre-test and post-test, we are now taking your attendance, okay? So, yes, I have seen one question asked by Vinita. So sometimes flow sensor is not used in ventilator. Is there any impact of it in the rate delivery or the pressure monitoring?
So if a flow sensor is not being used, it is a wrong practice, it is incorrect. If you're using a ventilator, to know whether the correct amount of air is being delivered, correct amount of volume is being delivered, a flow sensor is mandatory. So it should not be, patient should not be ventilated without the flow sensors. Monitoring has to be done along with ventilation. You can't just ventilate without monitoring. I hope that answers the question.
I think, Benita, you got the answer. Next question is asked by Jessie. Like, ma'am, what about the high inspiration alarm? Why it causes alarm?
Okay, but what do you mean by high inspiration? It can be due to two factors. So one,
Nakar, you want to ask something? Those who are not asking, please mute yourself. And if you want to ask any queries, raise your hand. We will give you access to unmute. Please mute yourself, those who are not asking queries.
so high inspiration, it can be due to three things. It can be a high respiratory rate. It can be a high tidal volume. It can be high minute ventilation. So you need to go and see in the ventilator which alarm is being given.
I think you got the answers.
Can you just read the question again?
Question second. Okay.
High inspiration alarm. Okay. So can you reframe your question? Which out of the three do you mean?
Jessie, can you please unmute yourself and you can ask your queries so that we will be a little bit more clear about your queries. Okay, we'll take up another question. Diana has asked the questions, ma'am. Could you please explain the pressure support ventilations and why we have to set low tidal volume and minute volumes?
Okay. So if you see the pressure support ventilation, it is the mode of ventilation where patient is given full autonomy. Patient decides when to breathe and how much to breathe. So if the patient tries to take breath, he will take a large breath. The volume, the pressure that is sensed by the ventilator, trigger will be sensed by the ventilator. Okay. What we are fixing in the ventilator is pressure support. Now, suppose if the patient is not generating this negative pressure, patient is not trying to breathe, the set pressure support will not be sufficient. So that will lead to a low tidal volume delivery. So if a low tidal volume is delivered and patient also breathes less, that is a respiratory falls, both of these will lead to multiplication and low delivery of minute ventilation. So this will lead to hypoventilation. Hypoventilation means delivery of low tidal volume. So this will lead to two things. One, hypoxia. Second, increase or accumulation of carbon dioxide in the blood. Now, once the carbon dioxide increases in the blood, this will lead to respiratory acidosis. Once the PCO2 starts to increase, it goes in 70s, 80s, and 90s, it will lead to CO2 narcosis. Patients can become unconscious. Patients can become hemodynamically unstable also. So that's the reason why you have to put the correct low tidal volume and minute ventilation alarm. So suppose I am 60 kgs and my minute ventilation should be somewhere around 3 to 3.5 liters. If I am breathing only 2 liters, so that is not sufficient. So I will set a low tidal volume alarm of around 250 ml, that is 5 ml per kg, and I will set a low minute ventilation alarm of 3 liters or 2.5 liters. Suppose I am breathing less than that. Now this alarm will start blinking and this will tell the ICU staff, whether the doctor or the sister, that the ventilator is not giving what is needed. So we need to increase the pressure support.
or we need to change the mode of ventilation. If the patient becomes fully unconscious, patient is not breathing at all, patient has stopped breathing. So we need to change the mode of ventilation to either a controlled mode or an SIMB mode. But it will be a mode where ventilator has more control over the ventilation. Patient will not be given full autonomy.
I think Diana, you got the answers. Next question is asked by Tangents. What do you mean if it's alarm high tidal volume?
Okay. So now again, the normal tidal volume we give to a person is between 6 to 10 ml per kg. If I give more than that, that is going to lead to volume trauma. There are various ways in patient can get trauma from the ventilator. One is barotrauma, other is volume trauma. If I give more than 10 ml per kg, it is not good for the patient's alveoli. It can lead to lung injury. So that's why we set a high tidal volume alarm also. For a 60 kg person, the highest should be 600 ml, not more than that. So that's why to prevent volume trauma, we put a high tidal volume alarm.
Okay. I think you got the answers. Another question is asked, like, what are the indications for putting a patient in a prone positions while on mechanical ventilations?
Okay. I'll answer that question, but you are going to have a separate question, session on this prone ventilation. So if you see the current literature for prone ventilation, it is only for severe ARDS. So you're going to have a dedicated class on ARDS as well. If patient is having severe ARDS, that means a PF ratio of less than 100. That is, the patient requires very high PEEP of more than 8, FiO2 of more than 80-90%. These are the patients who need muscle paralysis. They will need neuromuscular blockade for adequate oxygenation. Very sick patients, severe ARDS. These patients, it has been found when they are made prone and they are kept prone for 12 to 18 hours, more than 12 hours per day. It increases improves the gas exchange. It decreases the amount of FiO2 needed. So they are kept on prone ventilation. So the indication is severe ARDS on PEEP more than 8, FiO2 more than 80-90%, and need for muscle relaxant and deep sedation. These patients benefit with prone ventilation.
Okay, thank you. I think you got the answers. Actually, the positioning topic is separate. We will take a separate one. Another question is like how to use a PEEP in ventilator. Can you explain?
Okay, we will give you a small demo of ventilators, how to set mode and what all to see in the screen.
So we'll do the 5-10 minutes demonstrations after this discussion. So please be in the class. And which class we are not taking here, so we are not going to discuss this one. Again, it will be too lengthy. Anyway, this invasive ventilation class is too lengthy. So we try to make it short. We try to make it short and try to cover up what is important for you to understand. So we are not going to discuss that one. Thank you so much. Yes, I will share all the PPT in WhatsApp group. I have already shared that previous class PPT and this one also I will share. So don't worry. So that's why I'm sharing the WhatsApp group. Join the group. We will give there. Okay. I think till then we have this much questions. So we will show you 5 minutes demonstrations before ending our questions. So we will take one last questions like, ma'am, will you explain about what is the negative pressure ventilations?
Okay. So to understand negative pressure ventilation, you need to understand how we normally breathe. So the normal breathing, the quiet breathing that we usually do is negative pressure breathing. So whenever our brain senses that we should breathe, the phrenic nerve gets stimulated. The phrenic nerve will take the impulse to our diaphragm. When the phrenic nerve is stimulated, the diaphragm contracts. When the diaphragm contracts, what happens? It moves down. When it moves down, what will happen? The abdominal cavity will decrease in size. The thoracic cavity will increase in size or volume. So if the volume is increasing, the pressure will decrease. This is Boyle's law, PV. The product of pressure and volume is constant. So if the volume of thoracic cavity increases, the pressure falls. And gas or any liquid flows from an area of higher pressure to low pressure. So now the atmospheric pressure is 0. But inside the alveoli, the pressure has become negative. So air will passively flow from zero pressure to negative pressure. So this is called negative pressure breathing. Positive pressure breathing is what happens in ventilator, where a positive pressure is given by the ventilator, which is a higher pressure, and there is low pressure in the level of alveoli. So air again flows from higher pressure, that is a ventilator, to alveoli. That is positive pressure breathing.
Thank you, ma'am. I think you got the answer. So infections and all these are a separate class we will take up. So now we will do a 5 minutes demonstrations before ending the class. Okay, so.
Will I be audible? Will I be audible?
We'll try.
I like to
I think the screen is visible. I request everyone to mute yourself, those who are not speaking. Yes.
the image is coming. They won't be able to see.
Mirror image is coming.
Yeah. Opposite, can you see in the screen?
Yeah. Please mute yourself, those who are not talking. Catherine, can you please mute yourself? Catherine? Catherine, can you please mute yourself?
Yes, ma'am.
Bhuvneshwar, can you remove access to unmute themselves?
Okay.
Yes, I think the screen is visible. It's a little bit blurred. So.
Repeat, na?
Yeah.
Okay. So, am I audible?
Bhuvneshwar, we are audible?
Yes.
Okay. So, this is the ventilator screen, as you can see in your screens. Okay. So, every ventilator will have a different way of entering the settings, but it is more or less the same. Once you switch on the ventilator, you will see the screen. Okay. So, you will go to first settings, whether it is an adult or it is a pediatric, or it is adult. Then you can choose the sex, whether male or female. You will enter the patient height. I have entered it as 150 centimeter. So it will calculate the ideal body weight depending upon the sex and height. Okay. Then I will go to the modes. So there are 3 basic modes that we have discussed: pressure control, SIMV, and PSV. Apart from that, there are various other modes, 10s and 20 number of modes specific to every ventilator. But with just these 3 modes, basic modes, we can manage all patients. Now we'll go to the most basic mode, that is controlled mandatory ventilation. Okay. In controlled mandatory ventilation, the first setting that we are going to do is the respiratory rate. I've chosen a respiratory rate of 12. Then you select the tidal volume. So I'm going to start with 6 ml per kg, that is 360 ml. Then you can choose the PEEP. So every ventilator is going to have PEEP. We usually start with 5 and then increase if the need arises. The other setting is the IE ratio. Since the patient doesn't have COPD, we're going to choose 1:2. The other one is FiO2. So the fraction of inspired oxygen. We will start with the high FiO2 of 100 and then decrease as the need arises. Flow trigger is used only for SIMV mode and pressure support mode. It has no role in CMV mode. So we are going to keep it as high, around 5. Suppose we were using other modes where we want the patient to breathe spontaneously and we want the ventilator to sense it, we are going to decrease the flow trigger to the least. Here, the ventilator is going to sense even a small drop in the flow rate, 1 liter per minute, and then give the support to the breath. So once we have selected them all, we are going to confirm. Once the settings are done, we are going to start ventilation. So if we see a ventilator screen, there are two parts. The first one is going to show us what are the settings that we have set. Tidal volume of 360, PEEP of 5, FiO2 of 50. This can be decreased as needed. Now, as you can see that this ventilator is giving a low minute ventilation alarm. So the ventilator is not delivering how much is needed. So we go to the alarms and we see the settings. So for every ventilator, for every patient, you'll have to manually set the settings so that the alarms don't ring unnecessarily. High pressure limit alarms of 35, expiratory high minute ventilation of around 9. This is the low minute ventilation alarm, high frequency alarm of around 30, low respiratory frequency rate of 6. Tidal volume will have to be specific for each and every patient. And then this is the apnea alarm. The other side of the ventilator over here will tell you what is actually being given to the patient. So one is the peak pressure, minute ventilation, tidal volume, respiratory rate, and eye yield ratio. So there are two parts of the ventilator. The first one is the set rate, and the second one is what is actually being delivered to the patient. Apart from that, you will see two graphs which are moving with time. They are known as the scalars. First is a pressure scalar. Second is the flow scalar. So this will vary according to the mode of ventilation. This helps us in monitoring the patient, and it also helps us to troubleshoot for the cause for alarms. If you want to change the mode of the ventilator, you can go to mode and make other changes. CMV mode, SIMV mode, spontaneous mode. Then there are other intelligent modes that are specific to ventilators. This is a Hamilton ventilator. So it has an assist support patented mode and an intelligent mode, which are specific to these ventilators. But basic modes, just CMV, SIMV, and PSV are enough to manage nearly all patients. That's it. You can ask if you want to ask any questions.
Yeah. If you have any more queries, you can ask. I think everybody got the pre-test, post-test, feedback link. If you have any queries related to ventilator setup, you can ask. I'm sorry that the pictures we are not able to show you clearly because something. Thank you for those who have already submitted post-test. Bhunesh, can you once again share a post-test and feedback link here? Hello?
Yes. Sure.
Okay. So I think if there is any more queries, we will end the sessions here, I think. No, Dr. Neha? Okay, so Dr. Neha, thank you so much for wonderful sessions. Even though this topic is very vast, actually, we try to make it short and crisp. We try to cover up important topic which really will help you. So, and then demonstration also, we try to show you, but there's few pictures were not clear, so we are sorry for that one. And thank you for actively participating in the sessions, and thank you for those who have raised your queries. I hope you got